Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is pulmonary embolism. A pulmonary embolism involves one or more emboli, usually arising from a thrombus formed in the veins, obstructing the pulmonary arterial system. It's a life-threatening condition and causes respiratory distress, and may be unprovoked or provoked. Pulmonary embolisms affect 1 in 1,000 people per year and is more common with increasing age. 25% are unprovoked, another 25% are secondary to underlying malignancy, and 50% of people with pulmonary embolisms have underlying risk factors. These risk factors include increasing age, previous VTE, obesity, immobility, such as recent hospital stay and long-haul travel, malignancy, pregnancy, thrombophilia, oral contraceptive pill use, and cigarette smoking. A patient with pulmonary embolism will usually present with pleuritic chest pain and may have hemoptysis. They are usually breathless and will have palpitations. Fever is also present in up to 40% of cases, and they may also present with a frank collapse. In terms of signs to look out for when examining someone with potential pulmonary embolism, they may be tachycardic and tachypnic, there may be a localized pleural rub, they may be in new atrial fibrillation, and may also have hemodynamic compromise with syncope. They may or may not have evidence of a DVT, but it's important to examine fully for this. History and examination is key, as well as doing a full set of urgent observations when the patient presents. They will also require a chest X-ray, ECG and ABG. Bloods should be done, including a D-dimer depending on the Wells score, which we will discuss in the next slide, as well as a clotting screen and troponin, in addition to the other basic biochemistry and hematology tests. A CTPA or VQ scan will subsequently need to be performed in order to definitively find the embolism. Wells score is used to assess the probability of a PE. If the probability is low to medium, then it's advisable to do a D-dimer, and if it is high, it's advised to do a CTPA or VQ scan straight away. So these are the components of the Wells score. So they include clinical signs and symptoms of a DVT, the likelihood that PE is the number one diagnosis or equally likely, and both of those give you 3 points. And the other factors are a heart rate greater than 100, immobilization of at least 3 days or surgery in the previous 4 weeks, and previous objectively diagnosed PE or DVT, and each of those last 3 factors give you 1.5 points. If the score is 0 to 4, a PE is considered unlikely, and if the score is more than 4, a PE is considered likely. Suspected and confirmed cases of pulmonary embolism should be managed using an ABCDE approach, as it can be a medical emergency. Thrombolysis is indicated if there is hemodynamic compromise. Anticoagulation should be given as per local guidelines, and this may be treatment-dosed low molecular weight heparin, particularly if the person has a malignancy or is pregnant, or oral anticoagulation. Oral options include warfarin or a direct oral anticoagulant. An IVC filter may be inserted for those who cannot have anticoagulation or with a new PE despite anticoagulation. And finally, embolectomy can be considered in tertiary centres. So now let's try a question. A 30-year-old lady who is 6 days postpartum presents to the acute medical take with worsening shortness of breath and pleuritic chest pain. She is breastfeeding her newborn child. She is suspected to have a pulmonary embolism and subsequently has a CTPA which confirms the diagnosis. Which of the following statements is correct? So our options are she can be treated with a DOAC, treatment dose low molecular weight heparin is the most appropriate treatment for her, warfarin is a safe option by which to treat her, a thrombophilia screen is indicated, she can be ambulated if her blood pressure is stable. So the correct answer in this case is option B, which is that treatment dose low molecular weight heparin is the most appropriate treatment for her. It's important to remember in this case that she is postpartum and she is breastfeeding, and therefore automatically we cannot give her a DOAC or warfarin. A thrombophilia screen is not indicated here in this case because she has a confirmed risk factor. She has recently been pregnant, and it would be unsafe to ambulate her at this time, even if her blood pressure is stable, as she does have other risk factors. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.